Hi everyone, thank you for listening today. My name is Michelle. I'm the current PGY2 Oncology Pharmacy resident at Monument Health in Rapid City, South Dakota. And today I'm going to briefly go over a medication called tebentafusp, or also known by the brand name of Kimmtrak. I wanted to start off the presentation just touching on the indication of this specific medication. So tebentafusp was approved January 2022 for HLA-A201 positive adult patients who have unresectable or metastatic uveal melanoma. Aside from just being FDA approved, tebentafusp does have a place in the preferred regimens for the systemic therapy for metastatic or unresectable disease in the uveal melanoma guidelines here. So you can see it is a category 1 recommendation for those with HLA-A201 positive disease. Next, I'm going to talk about how tebentafusp works for uveal melanoma treatment. So this slide here shows the mechanism of action in the picture to the left, but this tebentafusp is a bispecific T-cell engager, consists of a soluble HLA-A201 restricted T-cell receptor that is specific for this glycoprotein 100 peptide, and it's also fused to an anti-CD3 single-chain variable fragment. So as you can see in the photo to the left, how it works is the T-cell receptor binds to a GP100 peptide that is presented by those HLA-A201 on the surface of the melanoma tumor cells, and then the CD3 binding domain ends up binding to the cytotoxic T cells, and that forms an immune synapse. With that, then the T cells will become activated. They'll release those inflammatory cytokines and those cytolytic proteins, and they'll end up attracting more T cells and more lytic granules, and that in turn will contribute to tumor cell death. This slide shows some of the trial data that supports use of tebentafusp for the current approved indication. This trial here was a randomized phase 3 open label trial, and this trial included adult HLA-A201 positive patients that had metastatic uveal melanoma, and these patients also did have an ECOG of 0 to 1, so good performance status in this population that was used. They did have 378 patients included in this trial, and then there was 252 patients in the tebentafusp group and 126 patients in the control group. Of the control group, 103 of those patients were getting pembrolizumab, 16 of those patients were getting ipilimumab, and 7 patients were getting dacarbazine. Patients were randomly assigned in a 2-to-1 ratio to either the tebentafusp or the investigator's choice of that single agent therapy. This is a summary slide of the efficacy data from this trial. So the median follow-up of this trial was 43.4 months. The median overall survival that they found was 21.6 months in the tebentafusp group versus 16.9 months in the control group. And then they found that there was a median progression-free survival of 3.4 months in the tebentafusp group versus 2.9 months in the control group. So overall, the study did favor the tebentafusp over the control group. The chart to the right shows, based off of group and the year number, the percentage of patients surviving. So it has the top group being tebentafusp, and then the bottom group being the control group, and it shows year 1, year 2, and year 3, and the number of patients surviving at each year. This slide shows 2 Kaplan-Meier curves from the study. The top Kaplan-Meier curve is showing the overall survival data that we discussed for the tebentafusp versus control, and these both just show the data in a little bit more visual way. The tebentafusp is represented by the orange line, and the control group is represented by the blue line. The bottom one is the progression-free survival Kaplan-Meier plot, and the lines are represented the same colors as previous. There were 16 patients in the control group that did cross over to receive tebentafusp after the primary analysis, so that is just one other thing I wanted to mention as well. Tebentafusp does carry several warnings. It carries a U.S. box warning for cytokine release syndrome, And then it also carries a couple other warnings, one being for dermatologic toxicity and another for hepatotoxicity. This chart shows the most common adverse reactions associated with tebentafusp in patients. Specifically, this chart is showing those adverse reactions of 30% or more of patients. CRS and rash are the main ones that I wanted to point out that are really the most common. CRS happens in about 89% of patients, and rash happens in about 83% of patients. Here's another chart just showing the most common laboratory abnormalities that have been seen with tebentafusp, specifically those lab abnormalities in 50% or more of patients. Now that we've discussed the most common adverse effects with tebentafusp, I wanted to show the adverse effects, especially the main CRS and rash, broken down by week per dose in a visual way. So this graph here shows the adverse effects. It has a category for all CRS and rash, and then it breaks them down by grade. The light blue is grades 1 through 2, and then the dark blue is grades 3 through 4. And it has this for each week, weeks 1 through 4. So you can see mainly most of the adverse effects were higher percentage during week 1. By week 4, still there were a lot of adverse effects, but they had gone down a little bit. I wanted to specifically pull out and talk about CRS. So in the trial, most of the patients that did have CRS, just to note, did have grade 1, that was about 12% of patients, or 2 at about 76% of patients, but there were about 1% of patients that did have a grade 3 event. This is a chart that exists on the Kimmtrak website just for CRS grading and management guidance with tebentafusp. So it is out there on the website if you do want to reference it for any reason. They do talk about how to grade based off of what symptoms the patient is having, whether we should consider holding the medication, if we should treat with corticosteroids, and then if we should pre-medicate with the corticosteroid before the next dose, and if we can go to the next dose or should permanently discontinue Kimmtrak, things like that. So I wanted to put this here so that you all could read this a little bit more in depth and reference this. They do also have this other section here for management of other side effects on the Kimmtrak website. This specifically especially touches on skin reaction management and elevated liver enzyme management. Another important topic I wanted to discuss is tebentafusp dosing. One thing I wanted to point out is before you even give the patient the infusion of tebentafusp, you should ensure the patients are euvolemic. This is really to minimize the risk of hypotension associated with cytokine release syndrome. So if the patient is hypovolemic for any reason, we may need to administer IV fluids just based on their clinical evaluation, their baseline vital signs, and their volume status, depending on what the provider decides. Another thing to mention is that the first 3 doses should be administered inpatient, and just of note, we don't do the first 3 doses at Monument Health in our facility. We have them do the step-up dosing with these first 3 doses somewhere else, and then we're able to do day 29 at Monument Health outpatient, or day 1 of cycle 2 essentially, since these are 28-day-long cycles. If the patient didn't have hypotension of grade 2 or worse during or after that 3rd infusion, that's really when it's okay for subsequent doses to be administered outpatient. And then I have the IV infusion dose schedule listed here. So essentially on day 1, they start with 20 micrograms. Day 8, they get 30 micrograms. Day 15, they get 68 micrograms. And then on days 22 and beyond, they get 68 micrograms once weekly until disease progression or toxicity. So really, this days 1 through 22 is essentially one cycle. And then after day 28 or whatever, on day 29, as I mentioned, that would start cycle 2. Another important thing to touch on with tebentafusp dosing is missed doses. So just compliance with this one, because it is step-up dosing, is really important. So it's really important to keep weekly infusions on schedule. They do mention that breaks in treatment, if needed, were allowed in the clinical trials for up to 2 weeks, but breaks for more than 2 weeks aren't recommended, as really the side effects at that point could occur at the same frequency and severity as a patient who is initiating treatment or those first 3 infusions, and also the impact on the outcome is unknown. So because of that and risk of CRS and other side effects just worsening, that's why it's really important to keep them on that weekly infusion schedule. That concludes my Kimmtrak presentation today. Please let me know if you have any questions. And here are my references that I used for the presentation. Thank you.